Kiara.
All
Thank you.
right, take it away. Good morning, thank you all for coming. So to sling or not to sling, I specifically want to look at the question of whether a simultaneous anti-incontinence procedure should be done at the time of pelvic organ prolapse repair. So I realize that this is about the third grand rounds this winter on stress urinary incontinence procedures, but we had a recent visiting professor, Dr. Christian Winters, and during our resident session, he stimulated my interest in this area. And I asked him what his opinion was on whether all patients undergoing a prolapse repair should have an anti-incontinence procedure done at the same time. And he's quite adamant that patients that are dry preoperatively should not have it done. So having looked at the literature now, I'm convinced that I agree with his opinion, but I want to convince you of that this morning myself. So some objectives to review the evaluation of the urethra at the time of pelvic organ prolapse, in patients with pelvic organ prolapse, and then discuss the rationale behind management options for the urethra at the time of prolapse repair. So a quick look at some terminology. Pelvic organ prolapse we know is a symptomatic descent of one or more of the either anterior vaginal wall, posterior vaginal wall, the vaginal apex, or vault. Clinical stress urinary incontinence is referring to the symptomatic stress urinary incontinence, so the patient's complaint of leakage. Urodynamic stress urinary incontinence is that demonstrated on urodynamics without prolapse reduction, and then occult stress urinary incontinence is that with prolapse reduced. So there's roughly about an 11.1% lifetime risk of having surgery for prolapse and stress urinary incontinence by the age of 80. We know that both come from similar origins with failure of the pelvic floor musculature and connective tissues, and that they both have similar risk factors. So they often coexist. About 50% of patients with severe prolapse will have clinical stress urinary incontinence, and about 25 to 80 will have occult stress urinary incontinence. So a quick look at the evaluation of the urethra in the setting of prolapse. It can present with a variety, prolapse can present with a variety of symptoms, including voiding, sexual, defecatory, and vaginal symptoms. With respect to the voiding symptoms, patients can present with LUTS or incontinence, but also the prolapse can mask any stress urinary incontinence due to urethral kinking or compression. So evaluation of the urethra is an important component of a patient with prolapse, and their symptoms may or may not be predictive of what you'll find on urodynamics. So history, you want to ask about obstructive symptoms, overactive bladder symptoms, any incontinence, and whether this is impacting their lifestyle and what their expectations are for management. Physical exam, it should be done in the lithotomy position, looking at the urethra for mobility, checking for stress urinary incontinence with a stress test, both with the prolapse reduced and unreduced. Also looking at any PVR and grading the prolapse itself. This should also be done in the standing position, repeated with a foot on the stool so you can see the severity of the prolapse and if there is any stress urinary incontinence. Looking at grading prolapse, there's a couple different grading systems. This is the POP-Q, which is quite tedious. It was meant to really standardize the grading system so that it could be communicated properly between physicians, also in documenting for research purposes. So it's tedious to use. A lot of people actually use the Baden-Walker instead. Urodynamics, it's not mandatory as part of the evaluation of prolapse and looking for stress urinary incontinence, but it's generally endorsed, looking for occult stress urinary incontinence before proceeding with surgery for the prolapse. Unfortunately, however, it's not standardized with respect to the method of reducing the prolapse. The goal with urodynamics is really to simulate the outcome of surgery, and so people have asked, is it actually an accurate simulation? Various methods are out there using a pessary, a speculum, vaginal pack, ring forceps, and depending on your technique, you could also be at risk of overcorrecting or causing urethral obstruction when you do the reduction. Also, the urodynamics may need to be repeated with catheter removed to check for the stress incontinence. And doing urodynamics will also allow you to look for detrusor overactivity or signs of voiding dysfunction or obstruction, which would be important if you're going to be placing a sling. So the suggested protocol for urodynamics is initially starting without the prolapse reduced, doing your Valsalva and stress maneuvers at about 50 cc intervals, checking for incontinence. If it's not demonstrated, to repeat this with a pessary or vaginal pack or whatever method to reduce the prolapse, checking again for stress incontinence. And if you still haven't detected it, to try removing the catheter and repeating the study. And lastly, urodynamics allow you to do the pressure flow study to again look for voiding dysfunction or obstruction. So looking at the management of stress incontinence with prolapse, there's a general consensus in the literature that if a patient is wet preoperatively, so if they have clinical stress urinary incontinence, that's the symptoms, and some objective demonstration of leakage, or urodynamic or occult stress incontinence in the setting of prolapse, that most people would agree that doing both a prolapse repair and a stress incontinence procedure is appropriate. Having said this, the literature behind this is not great. It's all basically level 2 evidence looking at uncontrolled studies showing that the risk of stress incontinence is lower if you do place an anti-incontinence procedure up front. So I wanted to focus more on the controversial area, which I introduced at the beginning, and that's if you have a completely dry continent patient preoperatively, is placement of a simultaneous prophylactic sling appropriate? So again, there's no level 1 evidence to support or guide our management. A couple of societies that, well, the Third International Continence or Consultation on Incontinence put out a statement. This said that incontinence and voiding dysfunction may follow prolapse surgery, and these outcomes are variable and unpredictable, which really isn't very helpful. And then the AUA guideline that was originally written in 2009 and then updated in 2010 for stress urinary incontinence surgery, they said that the surgical procedures for stress incontinence and prolapse may be safely performed concomitantly in an appropriately selected woman, and then that the panel doesn't have an opinion about prophylactic incontinence and prolapse. So again, not very helpful. So basically, there are different groups in the literature and in practice about what the correct opinion is. Some people, given that new onset stress urinary incontinence in prolapse or in a patient having recently had prolapse repair, would be quite devastating. These patients would say, yes, we should do a prophylactic sling up front, and recommend that all women undergoing repair of severe prolapse should have an anti-incontinence procedure placed. However, there's another camp that says basically the potential risks associated with an anti-incontinence procedure should be considered, including obstruction, mesh complications, de novo stress incontinence, de novo overactive bladder, and that no, not all patients should automatically have this done, and that it should be staged, and patients should be assessed post-operatively to see if they have stress incontinence before proceeding with an anti-incontinence procedure.
Is it significant that those statements came from urology and gynecology? The two specialties. Seriously, in general, look at that differently?
I think there's nothing official. I don't know about the gynecology literature, if they've actually put out a statement, but all the reading that I did is that there's no consensus, and it's still looking at the literature. So I just wanted to present a case, and then we can guide our discussion around the case. So it's a 56-year-old healthy female. She's active. She's had 3 vaginal deliveries, 1 C-section. She's on no medications. She did have an abdominal hysterectomy about 15 years ago for benign disease. She's been well up to 2 years ago, no voiding symptoms. She now presents with about a 2-year history of some bothersome local symptoms, vaginal bulge, some discomfort, no bothersome overactive bladder symptoms, mild urge, and no voiding symptoms. This is a picture. It doesn't do the cystocele justice, but it was actually a grade 3 cystocele. The urethra is well supported. She had stress tests both with and without the cystocele reduced. Both showed no stress urinary incontinence. She had then urodynamics. She had a non-instrumented flow, which is shown here, and that shows a normal flow. She did have a post-void residual of about 105. That was without the cystocele reduced. She then went on to have her CMG and pressure flow studies. This study is with the cystocele reduced. These basically show a normal CMG with no detrusor overactivity, no stress incontinence. And then the pressure flow studies show a normal flow with sustained good detrusor contraction and complete emptying. This is the study unreduced, and it essentially showed the same good bladder filling and emptying. She had a VCUG, these are lateral, and then an AP view of the cystogram, and it shows at rest and with Valsalva. And the catheter is in place in this one, so they measured the urethral angle. It was about 45 degrees. This is her with the catheter removed and a Valsalva demonstrating no stress urinary incontinence. Lateral views, again, this is with her voiding with a normal urethra, and then to the far right, having emptied completely. So in summary, the urodynamics excuse me, and VCUG show a normal CMG, no stress incontinence, and no voiding dysfunction. And that was both with and without the cystocele reduced. So a summary of the case, because we'll come back to it later. 56-year-old female, grade 3, symptomatic cystocele. She's continent, no clinical urodynamic or occult stress incontinence demonstrated. She has good bladder filling and normal emptying. So for her management, do we recommend just the cystocele repair, or should we do a cystocele repair with a simultaneous anti-incontinence procedure? So to answer that, I looked at the evidence and tried to guide my search based on these 4 questions. So the first was, what is the fate of a continent woman after prolapse repair without an anti-incontinence procedure, if we just leave her and do the prolapse procedure? What's her fate if we do both? And then can we confidently rely on our assessment preoperatively with urodynamics to tell if she does have stress incontinence or not? And lastly, do the risks of a prophylactic anti-incontinence procedure outweigh the benefits? So looking at that first question, there's about an 11 to 22% incidence of de novo stress urinary incontinence in a clinically continent woman if you just do the prolapse repair alone. People have questioned this number and have felt that it could be actually an overestimate, given the fact that these numbers were based on studies with clinically continent women that didn't undergo urodynamics. So they may well have had occult stress urinary incontinence that wasn't detected. And if so, we know that about 65% of patients with occult stress urinary incontinence will show postoperative stress incontinence, so it could have inflated the number. And on the flip side, another way of looking at this is, instead of asking how many continent patients are wet after prolapse surgery, we can ask how many would be dry if we just left them with the prolapse repair alone. And studies have shown about 90 to 100% will remain dry postoperatively. The CARE trial, which I'm going to describe in a bit more detail soon, looked at abdominal sacrocolpopexy and prophylactic anti-incontinence procedures. And they found in those patients without occult stress urinary incontinence, the people that we're interested in, completely dry, had about a 62% risk, a 62% chance of remaining dry. Therefore, if we're going to do an anti-incontinence procedure on everyone with prolapse, we could risk doing this procedure in a continent patient with bladder outlet obstruction. And that's basically because in the literature it's been shown that stress incontinence does coexist with voiding dysfunction, and even patients that have no occult stress incontinence, completely dry, as shown in the CARE trial, these patients have been shown to have obstructed voiding as well. They looked at their urodynamic data and found that 60% of their urodynamics showed obstruction, and about 30% of these patients had obstructive symptoms. So if you're going to be placing a sling in everybody, not only would you be at risk of placing it in somebody that's dry, but in somebody that's potentially has symptoms or signs of obstruction as well. This also is relevant in elderly patients that may have a hypocontractile bladder in addition to obstruction. So the answer to this question was, so what is the fate of a continent woman if you just do the prolapse procedure alone? It's that the majority of women will actually stay dry after just the prolapse procedure, and that women with stress incontinence may have this coexisting voiding dysfunction, and you have to be aware because you could be placing it in somebody that has obstructive voiding in the first place. So the second question to guide my literature search was, what is the fate of a continent woman after the prolapse procedure and the anti-incontinence procedure? So there's about a 0 to 24% risk of stress incontinence after simultaneous procedures. These studies, this number is based on studies that included patients both with and without preoperative stress incontinence. When we look specifically at our population of interest, the dry patients, the CARE trial does answer or provide some answers. So I'm going to just take a minute and describe the CARE trial. Basically, it's the only large randomized controlled trial evaluating the performance of an anti-incontinence procedure at the time of prolapse repair. There's 322 women that had no sign or admitted to no signs or symptoms of clinical stress incontinence. They were undergoing abdominal sacrocolpopexy. The patients were randomized 157 to a concomitant Birch procedure and 165 to just the prolapse repair. 36% of these patients did have occult stress urinary incontinence. So at 3 months postoperatively, they found that 24% of the women in the Birch group versus 44% of the women in the control group, regardless of their urodynamic status preoperatively, had stress incontinence. And then in our specific population of interest, those without any occult stress incontinence, found that with a Birch, it did reduce the incidence of post-op stress incontinence from 38.2% to 20.8%. So this trial was actually stopped early at their first interim analysis due to the positive findings from the Birch. It also noted that there was no increase in LUTS or retention by placing a Birch concomitantly. So the finding that the Birch in combination with the prolapse repair reduced stress incontinence in patients that were clinically continent basically led to people to believe that we should be placing simultaneous slings in everyone that's undergoing severe prolapse repair. There are some problems with that argument. Basically, the results of this can't be generalized given the fact that it was an abdominal procedure, can't be generalized to transvaginal prolapse repair. It also can't be generalized to other anti-incontinence procedures besides the Birch. In addition, there was a 2-year follow-up study that looked at these patients and found that still 1/3 of the patients, despite having a prophylactic Birch, were leaking. Also, there's been some difficulty reproducing these results in subsequent studies. And in fact, one study actually that was well designed but just small showed the exact opposite, that actually placing a Birch, you'd have a higher risk of stress incontinence. So getting back to our population of interest, the women without occult stress incontinence, dry. Remember I said that 62% of these women in the CARE trial remained dry, regardless of despite not having a Birch done at the same time, which means that 38% of the continent women that had stress incontinence with prolapse repair alone versus 21% of those that had the Birch as well as the incontinence procedure. So really you're only decreasing the risk by about 17%, and we know that this procedure can fail in about 30% of the patients, which is demonstrated in that 2-year follow-up study. So this limitation in efficacy must be considered in the context of the complications that we can cause by doing this upfront. So besides the Birch, the mid-urethral sling is also a common procedure performed by urologists. It's actually the most common one during a prolapse repair, and it's not perfect. The TVT objective cure rate is about 63 to 80% at 5 years. The Spark objective cure rate is 72 to 80% at 2 years, and only 25% of women report absence of leakage under any condition at all. So the question that I posed, what is the fate of a continent woman after prolapse repair and the anti-incontinence procedure? The answer is approximately 20% chance that they're going to still leak, and that's similar to the risk of stress incontinence with prolapse repair alone. And we could offer an imperfect operation with a 20 to 30% failure rate, but there's no guarantee it's going to prevent stress incontinence, and also it only reduces the risk by 17%. So the third question was, can we confidently rely on urodynamics or our urodynamic assessment preoperatively to decide the functional status of the urethra, basically if the patient's dry or not? So the majority of women we know with prolapse do have occult stress urinary incontinence. I said it was about 25 to 80%. So in order to identify these patients without occult stress incontinence, and those are the patients we potentially could spare from having this anti-incontinence procedure and the risks that go with it, we need a reliable test. Unfortunately, the detection of occult stress urinary incontinence isn't standardized. There are multiple methods to reduce prolapse, listed here: manual, pessary, the split speculum. And all of these methods have been shown to have low sensitivity and positive predictive values with reasonable specificity and negative predictive values. However, despite these statistical limitations, there have been many studies that show it is still feasible to diagnose patients with occult stress incontinence with consistency, as demonstrated in this table. And we know that the majority of the continent women that do not have occult stress incontinence, we know that the majority of women that do have occult stress incontinence should go ahead and have the anti-incontinence procedure, based again on level 2 evidence. Being able to detect occult stress urinary incontinence will allow surgeons at least to counsel their patients, and it just must be conveyed that if there is a negative test preoperatively, it doesn't guarantee that they're not going to leak postoperatively. So it could be a tool. So in answer to this question, I believe, yes, we can consistently diagnose patients with prolapse with occult stress urinary incontinence, and this will allow us to identify those patients that we can spare the risk of the simultaneous incontinence procedure. The last question is, do the risks of prophylactic anti-incontinence procedure outweigh the benefits? So in basically the relative benefit and harm of routinely adding an anti-incontinence procedure needs to be addressed with every patient. Specifically looking at the complications, about 20% of women who undergo these procedures do have complications. These range from difficulty in voiding to urgency, incontinence, urinary tract injuries. Due to registries and databases, we have some numbers. Looking at those that require catheterization after this would be about 6%, 2.4% require tape incision, about 10.2% require or acquire de novo urgency. Also, local complications can occur: vaginal extrusions, erosion into the urinary tract. Studies have actually looked to see whether the reported complications in the general literature match up with the FDA reported complications. We know they do not, and more catastrophic injuries have been reported on the FDA website than in the general literature, which prompted the advisory from the FDA about mesh. So in addition, moreover, studies have also shown that if you do these procedures simultaneously, you may even be at a higher risk of complications from the anti-incontinence procedure, such as prolonged retention, more voiding dysfunction, and longer hospital stays. This was an interesting study by the NITI group by Ballard. Basically, it was looking at their protocol for using urodynamics to decide which patients they should put a prophylactic sling in. And the boxes in red basically show the risk of complications after placing a sling compared to the box in green, which shows the risk of requiring a secondary stress urinary incontinence procedure. And in fact, the numbers actually are quite similar. So it's about 8.5% for the risk of a complication and 8.3% for the risk of requiring a stress urinary incontinence procedure at a delayed time. So you're really not, by placing one up front, you're not really saving any trips to the OR, because the risk of requiring a surgery for stress incontinence is equal to the complication rate. So in general, for conclusions from the literature, basically there is no consensus, as far as I could tell in the literature, about whether you should be doing a stress incontinence procedure up front in a dry patient. That it does boil down to the patient's choice with good physician counseling. So telling the patients that the majority of continent women will not leak after just a prolapse repair alone. That's about 20% of patients will leak after the prolapse repair alone. That we could offer them an imperfect solution with about a 20 to 30% failure rate, but there's no guarantee it's going to prevent their stress incontinence, and you're only reducing their risk by about 17% based on the CARE study results. That there is potential for significant complications, and potentially these could be even harder to deal with than just de novo stress incontinence and putting a sling or an anti-incontinence procedure of your choice at a later date. Also, based on the study I just showed you by NITI, that the risk of intervention for a sling complication is roughly equal to requiring a sling for de novo stress incontinence. So you're not decreasing the number of operations, and potentially you're not introducing a risk up front that could be potentially irreversible. Again, management would depend on the surgeon. Shlomo Raz put out a study stating that he had less than 1% risk of retention with his distal urethral slings, and that doesn't compare to the 8% that we just saw in the NITI trial. So overall, in the average surgeon's hands, I think that the safest approach would be to expose patients to the risk when it's clear that they need it, when they demonstrate stress incontinence after prolapse repair, and don't create a new problem up front and observe for the stress incontinence to come postoperatively. So these are just a couple algorithms from an AUA update series. This one agrees with what I've tried to argue today, basically saying that if they're clinically incontinent urodynamically or occultly incontinent, to go ahead and place a sling at the time of the prolapse repair. However, this algorithm differs slightly from what I'm arguing. It agrees with the CARE study results. In patients that have an abdominal sacrocolpoplexy, they do recommend going ahead and placing it prophylactically, as they did in the CARE study. So future directions in this area would be doing a large randomized control trial to look at the usefulness of urodynamics in patients which are undergoing simultaneous procedures, trying to assess the best method for prolapse reduction in doing the urodynamics, and then looking at the optimal anti-incontinence procedure to perform, and whether this differs based on the surgical approach for the prolapse, vaginally or abdominally. So just to look back at the case, a summary where we had left off, it was a grade 3 symptomatic cystocele. Patient was continent, no clinical urodynamic or occult stress incontinence, normal bladder filling, and emptied well. The management chosen was a cystocele repair with a simultaneous TOT. Postoperatively, the patient did develop new onset overactive bladder symptoms, frequency every hour, nocturia twice at night, some urge incontinence, slow flow. Early postoperative PVRs were 600 to a liter. She did have to learn CIC, discontinue this due to frequent UTIs, and then she was lost to follow-up. About a year later, she presented with mixed storage and voiding symptoms. She had urge incontinence, no stress incontinence, Her voided volumes are about 150 to 250 cc's with elevated PVRs of 300 to 400 cc's. Her exam showed no prolapse, no urethral hyperelevation, and no mesh exposure. This is her uroflow. It's a non-instrumented flow. It's slightly prolonged, and she did have a significant PVR of 650 cc's. Her CMG is normal. Pressure flow studies showed obstructive voiding with a detrusor pressure of 32 and a maximum flow of 11. PVR on this one was 368, and she had an active EMG during voiding. This is a VCUG in the lateral view with Valsalva that demonstrated no stress incontinence. This is her voiding in the lateral view. It shows a spin top type configuration of the bladder neck and the urethra narrowing distally, and her post-void view there. So in summary, she had a normal CMG. She did have urodynamic findings of bladder outlet obstruction on all three, her pressure flow study, on the VCUG with a spin top urethra, and then with her consistently elevated PVRs. On cystoscopy, she did have some mild trabeculation, which is hard to appreciate here, but also had a small diverticulum. So she underwent TOT mesh incision to start bilaterally. Unfortunately, she had no change in her symptoms. And she had a trial of urethral dilatation under general anesthetic, again unsuccessful. And lastly, did require a full TOT mesh excision. So currently, she is voiding to completion, requiring no CIC. She does have subjectively a low flow. However, she has persistent overactive bladder symptoms. She has daytime frequency and urgency every hour, and it gets up at night twice. She does have urge urinary incontinence and wears a panty liner daily, and she does have some stress incontinence with lifting occasionally, and she has no UTIs. So essentially, she is left with a potentially permanent complication of the de novo overactive bladder. So that is it. Short but sweet.